Hello. In this presentation, we will be reviewing the procedures completed by the blinded medical clinicians, or BMCs, in the study. So, what will the BMCs be doing in the study? First, they will participate in the medical assessments that are conducted at screening and baseline. The unblinded medical clinicians may also perform the screening and baseline assessments prior to randomization. If an adverse event occurs prior to randomization, either a blinded or an unblinded medical clinician may evaluate it. After randomization, this task is delegated strictly to the blinded medical clinicians. The BMC will also confirm safety for dosing, determine potential dose escalations, make emergent trial-related medical decisions, and provide backup for after-hour emergencies. There are two types of blinded medical clinicians. At least one BMC at each site must be a physician. That person is required for confirming eligibility on the medical history CRF, must be the decision maker for any dose increases or decreases, and for making trial emergent medical decisions. In particular, the BMC physician will work with the lead team to determine if participants should be withdrawn from medication, should be withdrawn from the study, or if there is a need to request an unblinding. For other blinded medical tasks, a non-physician BMC, such as a physician's assistant, nurse practitioner, etc., may assume those tasks commensurate with their training and licensure. This includes providing approval for administering the weekly injection of an ongoing dose level. Now let's talk briefly about adverse events. As a reminder, an adverse event is any untoward medical issue that occurs following consent through the end of the week 30 follow-up period. Research staff will be asking about adverse events at each study visit except during the initial screening visit. If screening occurs in more than one session, then staff will ask about adverse events in each subsequent visit for screening. Staff will elicit adverse event information by asking a simple, open-ended question, such as, "How have you been feeling since your last visit?" If the participant reports any medical concern, staff will capture that on a paper copy of the adverse event form and then provide it to a blinded medical clinician to review the information and to determine severity, causality, and seriousness. All reported adverse events will be followed until they are resolved or until 30 days after the participant's week 30 visit. The following adverse events are of special interest for this study, based upon previous studies conducted with tirzepatide in persons with diabetes and obesity. Severe hypoglycemia associated with severe cognitive impairment requiring external intervention, a BMI of less than 18.5, a major adverse cardiovascular event, hepatobiliary disorders, severe GI events, acute renal events, suicidal behavior, pancreatitis with 2 or more of the following: upper abdominal pain, amylase or lipase 3 times the upper limits of normal, or imaging showing inflammation of the pancreas, C-cell hyperplasia, or allergic and hypersensitivity reactions. All of these adverse events of special interest will be reported on the SAE form regardless of whether or not they meet criteria for an SAE. Adverse events are classified into one of 3 categories: mild, moderate, or severe. BMCs will assess severity based on the parameters set forth in this table: level of discomfort, level of intervention required, and impact on daily activity. When determining causality, clinicians will need some information regarding the context within which the adverse event occurred. For example, did the event start soon after medication was administered, or was it existing prior to the receipt of medication? Has the participant reported similar events for this type of medication in the past? Is the event a known side effect of the medication? Do the symptoms improve as the medication wears off throughout the week and then return upon an additional injection? You are looking for a reasonable possibility that the study drug caused the event. As this is a blinded study, you can't say for certain that the event was caused by the medication because you don't know whether they're receiving active medication or placebo, but simply provide a determination as to whether the context indicates a reasonable possibility of causality. There is a specific category of adverse events that requires special handling in terms of reporting. This is known as a serious adverse event. Please note that seriousness is not the same as severity as far as research is concerned. It is entirely possible for someone to have an event of moderate severity, for example, that is classified as serious. For example, someone may be hospitalized for observation after falling and hitting their head with ensuing moderate symptoms. The fact that they were admitted to the hospital makes this a serious adverse event. If any adverse events result in death, a life-threatening event, a hospitalization or the prolongation of an existing hospitalization, significant incapacity, or other important medical event that jeopardizes the patient and requires intervention to prevent one of those outcomes, then that is considered a serious adverse event. Also, if the participant becomes pregnant during the course of the study and the baby is born with a congenital anomaly, that is also a serious adverse event. In the TAB study, there are some events that would ordinarily be captured as serious adverse events, but are going to be exempt from reporting as such. First, admission for detox will represent worsening of substance use disorder and will be captured as an AE only. Hospital admission for labor and delivery or for elective or pre-planned surgery will also not be captured as a serious adverse event. This study also has a number of CRFs listed here that will capture safety data instead of that being captured on the adverse event form. For example, if someone has some redness and pain at the injection site, that will be captured on the injection site reaction form, not the adverse event form. Now let's see how much you've learned. Blinded medical clinicians must be a physician in order to do which of the following? A. Perform screening assessments. B. Determine study medication dose increases and decreases. C. Evaluate adverse events. Or D. Provide backup for after-hours emergencies. And the correct answer is B. Only a BMC physician may determine study medication dose increases or decreases. Here's the next question. Events not required to be reported as serious adverse events include A. Admission for detoxification, B. Admission for labor and delivery, C. Admission for elective surgery, D. All of the above, or E. Both B and C. And the correct answer is D. All of the above. Next, post-randomization, a BMI of less than 18.5, acute renal events, or suicidal behavior are A. Serious adverse events, B. Excluded from needing to be reported, C. Adverse events of special interest, or D. Reported only on study forms other than the AE or SAE form set. And the correct answer is C. Adverse events of special interest. Now let's talk a little bit about the process for weekly dosing. Prior to the weekly injection, study staff will check to see if the current week is associated with a potential dose increase. They will also gather any safety concerns that have been reported since the last injection. If no dose increase is possible, staff will provide any blinded study medical clinician with the prior week's dosage and any new safety information. The BMC will review the information and confirm approval to administer the injection. If there are concerns about the safety of that dose and the BMC is not a physician, the BMC will instruct the staff to discuss the concerns with the BMC physician for approval to move forward or to potentially lower the dose prior to the injection being administered. If this is a week in which a dose increase is possible, study staff will run the dose escalation report in eClinical and provide it to the BMC physician. They will then review the report and determine whether the dose may be increased and then provide approval to administer an injection of the appropriate dose. If the determination is made that a potential dose increase is not appropriate, the BMC physician will communicate the reasoning to study staff, who will then complete the dose increase form based on that information. Now, as much as we hope the participants will attend every visit and receive every injection, we know that there is a strong likelihood that we will encounter missed doses during the course of the study. In general, a missed dose may be made up as long as it can be done within 4 days following a missed injection. If the missed dose occurred more than 4 days prior, that week's dose will be skipped entirely, and the next week's dose will be given on its regularly scheduled visit day. If a participant misses more than 4 consecutive weeks of dosing, they will be reinitiated at 2.5 milligrams weekly upon return. Both at screening and throughout the study, we will be reviewing prior and current concomitant medications. BMCs will need to review any changes, additions, and/or discontinuations to medications to ensure that the participant may still safely engage in the study activities. Red light medications shown here are those which are contraindicated in the protocol. Yellow light medications include oral contraceptives and any other medication administered orally. Tirzepatide delays gastric emptying and thereby has the potential to impact the absorption of concomitantly administered oral medications. Caution should be exercised when oral medications are concomitantly administered with tirzepatide. Monitor patients on oral medications dependent on threshold concentrations for efficacy and for those with a narrow therapeutic index, for example warfarin, when concomitantly administered with tirzepatide. For protocol requirements, participants using oral hormonal contraceptives should be advised to switch to a non-oral contraceptive method, for example a birth control injection, an intrauterine device, or an implant, or add an additional birth control method, for example, birth control pills with a barrier method, like a condom. Moving to the green light, it is important to note that other forms of MOUD are not contraindicated for tirzepatide. So, participants who discontinue buprenorphine but switch to methadone or naltrexone during the course of the study will continue to be offered their studied medication. Unless there is a clinical concern, all participants will increase from 2.5 milligrams to 5 milligrams after 4 injections of the 2.5 milligram dose. It will be okay for someone to stay at 2.5 milligrams if there's a clinical concern to prevent them from increasing. We do not expect this to happen very often, though. After increasing to 5 milligrams, participants may have the opportunity to increase their dose after 4 injections of their current dose in 2.5 milligram increments, up to a maximum dose of 15 milligrams. As noted earlier, study staff will run a dose escalation report in eClinical and provide it and any unresolved adverse events to the BMC physician prior to making a dose decision. If a dose escalation is being considered for a visit at which those 2 assessments are not normally completed, staff will have the participant complete an ad hoc gastrointestinal symptom rating scale and an ad hoc modified promise-based opioid use monitor. Let's take a look at what that dose escalation report looks like. Those items circled are the ones that the BMC physician will look at to determine if the person is eligible for a dose increase. In this example, the person actually gained weight, and the negative 0.25 indicates that there was no weight loss and a 25% weight gain. Weight loss would be indicated by a positive number. The arrows point to guidance on whether or not a dose increase is okay. In this example, the MOUM or the CRF-POM indicates well-controlled craving, but the urine drug screen results are positive for illicit opioids and/or stimulants. So, although the MOUM would indicate that the person is not eligible, the urine drug screen indicates they are eligible. Let's look at the criteria for dose increases to determine whether or not this person is eligible. Let's look at the specific criteria for a dose increase. For the first dose increase from 2.5 milligrams to 5 milligrams, only the first 2 bullet points apply. That is, they have received at least 4 injections at the current dosage and are tolerating the current dose. For tolerating the current dose, we will look to see that the participant has not lost more than 15% of their body weight since baseline, that they have not reported any symptomatic hypoglycemia, and that they are not reporting any GI symptoms that are impacting their day-to-day functioning. The remaining 3 bullets apply only to increases beyond 5 milligrams. For the UDS and the MOUM or POM bullets, please note that the criteria say and/or, so both are not required. In the example on the previous slide, the person's craving was under control. However, since the urine drug screen was positive, that person is eligible for a dose increase. As noted earlier, a dose increase form will be completed at each visit to indicate whether or not a dose increase occurred at that visit. In many cases, the study staff will be entering that no increase occurred due either to not being due or due to the participant not yet having 4 injections of the prior dose. If there was a potential for a dose increase, study staff will consult with a BMC physician to determine whether to indicate that a dose increase occurred, or if not, the reasons why no dose increase occurred. If the participant is not tolerating their current dose, or if there is an emergent medical issue that would be affected by the current dose, the BMC physician may determine that a dose decrease is required. The study medical team will provide follow-up assessments and referral for treatment as needed. There are a few instances in which the protocol requires that medication is discontinued. If the participant's BMI decreases to 20 or less, their medication will be discontinued. However, if their BMI later increases to above 20, the BMC physician may determine to restart them at 2.5 milligrams if they feel like that's clinically appropriate. If a participant who is sexually active and of childbearing capacity reports no longer using adequate birth control and is unwilling to do so, they will be discontinued from medication. In this case, if the participant returns to using adequate birth control, they may be restarted at 2.5 milligrams with the approval of the BMC physician. If the participant has a glucose reading below 70 during a hypoglycemic episode, becomes pregnant, or is determined to have significant active suicidal ideation as confirmed by the QMHP, they will be discontinued from medication with no opportunity to restart during the remainder of the study. There are also several reasons for which the BMC physician may determine that a temporary medication discontinuation is needed. These may occur due to an acute medical problem or due to a situation like hospitalization or incarceration where continuing the medication is not logistically possible. The BMC physician is responsible for assessing for safety to return to study medication once the situation leading to the temporary discontinuation is resolved. For situations involving the need for permanent discontinuation, including those spelled out in the protocol, the BMC physician will consult with the lead investigator and the CCC's medical monitor prior to permanently discontinuing the medication. It is important to note that discontinuation from medication does not equal discontinuation from the study. We want participants to continue in all other study activities even after their study medication is discontinued. TAB is an intent to treat study, which means basically once a participant, always a participant. Participants will remain enrolled until they finish the study, withdraw consent, or die. However, there are occasionally some situations in which it is no longer safe for the participant to remain in the study. That may be because the participant is a threat to the safety of others, or that there are other safety concerns that would make the participant's continuation in the study unsafe for them. In this case, the BMC physician will consult with the lead investigator and the CCC safety monitor to discuss permanently withdrawing a participant from the study. Please note that if a participant is terminated from the study early, they will not be replaced. Once again, let's review a few things you've learned. A participant may be eligible for a dose increase after being on their current study medication dose for how many weeks? Is it 4, 6, 8, or 2? And the correct response is A, 4 weeks. Next, true or false? A participant must be discontinued from the study medication if they have a hypoglycemia episode in which the lowest glucose reading was below 70 milligrams per deciliter. True or false? And that is true. And finally, true or false? Participants who are permanently discontinued from study medication must also be discontinued from all other study activities. This one is false. If a participant is discontinued from study medication, we still want to retain them in the remainder of the study activities to the extent possible. And that's it. Thank you for joining me for this discussion of blinded medical clinician procedures. Please reach out if you have any questions. Thanks.